cases.
Right. Thank you very much for the introduction, Felix. Thank you very much for inviting me, coming here back home in the Berlin family. It's always wonderful. Yesterday evening, today. It's a big pleasure, and it's certainly an honor to be here. I got this title from the organizers, and I was wondering about how can I start and how can I end with this topic. And the rhythmic end of a long story, of a long day, maybe it was meant. And maybe I had the feeling of a little bit of a depression when I was reading this, because the end from the arrhythmic side is what we typically find in patients, whatever reason of these are the two ends you can have with your heart from an electric perspective. The hyperdynamic and the adynamic version. And looking in our data, we were a little bit surprised that AV channel was not the major topic we were dealing in the last 25 years when I'm in my job in electrophysiology. In congenital heart disease, AV channel for sure is a topic, but it's not one of the major topics. But I will guide you within the next minutes through this. And I apologize for the lines that were a little bit mixed up when I put my presentation from the Mac to the PC world. It is still not matching perfectly. And I was thinking how to summarize this. For sure, we have substrates that are in these patients seen at random. They can be inherited, so associated to the congenital heart defect. They can be acquired by surgery, and I will go a little bit into this. And we heard during these 2 days about that too. And they can be for sure acquired by aging or remodeling process. And I will focus for the beginning for the slow arrhythmia substrates. And we know, even looking at the normal EKG, and I just repeat what you heard yesterday and today from Yen Ho's talks and from the surgical talks. Maybe this is my role, just to put these pieces together, what we learned anatomically to the EKG. We know that the typical EKG is at least an AV block 1, what we find in most of the cases. We have a funny axis of the Qrs complex. We have a left rotated axis with some kind of a right ventricular delay. And this is, let's say, this is the start with the EKG, what we find in the surface EKG when we make an EKG at the young patient. This is from an EKG Atlas 1971, so that's pretty old, but it didn't change so far. This is very actual, I would say. And on the left panel, you see the EKG of a 2-month-old patient, baby with an AV canal and mitral valve dysplasia, and this is at the age of 15 months. And you can see the prolonged PQ time, so this is very normal, and you can see after these 13 months that the R delay, the right ventricular delay, just enhanced. So there is some process going on. And you have seen maybe these pictures, and you remember these pictures from Bob Anderson. This is the anatomy of the physiologic conduction system in a normal heart on the left panel, and here on the AV canal. And I just would like to go quickly through this again. This is the coronary sinus ostium. This is the fossa ovalis. This is the tricuspid valve annulus. This is the tendon of Todaro. And everybody knows here in the room that this is the triangle of Koch, named, where we all know there's a compact AV node. The interesting thing always is that the surgeon has no way to see this anatomical structure or this electroanatomical structure, and we as electrophysiologists, we can't see it either. So putting even a catheter at this place, we don't see any remarkable signal telling us, so there's the AV node. So this is a little bit a miracle, especially when we have a big hole in the membranous septum, as typically in the AV channel. So these are the markers for the triangle of Koch, and you learned already through these 2 days, and you knew before, I'm sure, that the AV node, the compact AV node, is displaced. It's anteriorly, so more ventricular, it's outside the typical marks of the triangle of Koch. The other thing is that the course, the penetrating course towards the ventricular level through the fibrous body is displaced, is prolonged, and the left anterior hemifascicle is typically dysplastic or blocked, and we have a prolonged conduction toward the right ventricle and towards the inferior left ventricle. In summary, this makes the typical EKG. And I'm quite sure that Yen has shown this already before. These are very, very old studies, but again, still actual. Sections from atrial to the ventricular level, and look at the AV node, which is sected here, and you see the orifice of the tricuspid valve annulus, or the tricuspid valve ring, the bridging leaflet, penetrating bundle here, very, very close to the valvular area. This is the bridging valve, and you can see just below, here's the common atrioventricular bundle, now going towards the right ventricle, and a very, very slim one to the left ventricle. So very, very thin structures, all in summary explaining the EKG when we see a native patient with an AV channel in the surface EKG. So without an echocardiogram in your hand, you could make maybe the diagnosis already looking at the EKG. Just to remember, this is normal anatomy with the same sections. You see the AV node, you see here the tricuspid annulus membranous septum, and you see here these big pieces of meat, electrical conducting tissue dividing into the right bundle branch and the left bundle branch. You can see here very superficial. This is all for all interventionists, very interesting. If you put your catheter down here, you can block this easily. Another factor, next to the anatomical factor, what I found to be interested to be discussed here is a genetic factor. We learned 10 years ago already from works from Charlie Barul from the US, that there are other factors responsible for the delay of conduction tissue. And this is if we are missing a gene which is expressing a hormone which is protecting the tissue from apoptosis, from early apoptosis. This is the NKX gene, which is coding on the one hand some kinds of congenital heart disease, but on the other hand, it is blocking a hormone which is protecting from early apoptosis. So this could be one of the explanations why we can survive surgery on the AV canal with maybe an AV block 1, but after 5 to 10 years, we have an AV block 2 or 3 degree. Not only fibrosis, not only, let's say, remodeling, this could be one of the factors, a genetic factor, but they are still working on that, and I'm expecting more results on this. Then with surgery, years after, as discussed with surgery, years after surgery, surgical trauma, we have been discussed this within these 2 days, extensively just running through this. This is an elder patient with a prolonged PQ situation, now another patient with a pacemaker relevant AV blockade, and you can see that this patient is already paced on the atrial level too, so sinus node disease is another factor what we see in these patients, maybe according or maybe related to this gene defect. Again, big respect for the surgeons, what they do. This is the typical anatomy of the tricuspid ring, membranous septum. We have here the typical borders of the triangle of Koch. Coronary sinus roof, let's say, the tricuspid valve annulus, the septal portion, and the tendon of Todaro. And if we have the same situation in the patient with, let's say, for example, a complete AV canal defect, all these markers are gone. This would be, by definition, the area where we would expect the compact AV node to be placed, but it's, as mentioned before, it's placed ventricularwards. And the course of the penetrating bundle is just beneath the bridging leaflet, so it's just waiting for a stitch to be made from the surgeon. And you see the more distal part of the right bundle branch is just running on the surface of the crest of the defect. So this is waiting for really just stitching or stretch. So this is something, I would say it's no wonder that AV block, postoperative AV block is still an issue in these patients. And I was just looking for some data, and I have to apologize, but there are not too many data today about AV block rate in AV canal repair. So we learned, and I learned in this session again, we have other issues where we are looking at, but AV block more or less is accepted to be around, let's say, a little bit below 1% and 1.5%, depending on which center is doing it and what is the severity of the defect at itself. But still, it's not below. And this is from the South American group. This is maybe a little bit more unfortunate with 12%. We have another group here, for example, all partial AV canal, again 1.7%. Rate of AV block requiring pacemaker after surgery. And this is a very actual study. So this is a present problem we are still facing. And another study here, this is a mixed patient cohort. They had 1,550 patients, and AV block was transient in 4.5% and 2%. It was complete. And among the major diagnoses being behind these patients, complete AV canal, no wonder, is one of the major players for this. So for the rest of my talk, just concentrating on the fast. And thinking about the fast, it came to my mind, first of all, taking about the pain in the neck issue. This is CHET, postoperatively acquired CHET, and everybody working on intensive care unit from the conservative side or from the surgical side knows these problems. We know the EKGs, out of time reasons, I don't go into details with this. Everybody knows narrow QRS complex, sometimes VA dissociation, sometimes they are connected. So these are old rules. Let's say VA dissociation as one of the requirements to make the diagnosis of CHET, but it's not. We know there are different conduction situations towards the atrium, but anyway, it's a pain in the neck situation because it is a life-threatening arrhythmia we can have in the early postoperative period. Because of typically it's high rate, and we know the mechanism today is enhanced automaticity. So it's a focal enhanced automaticity of the specific conduction system tissue, or typically originating from the compact AV node or the distal portion, so being close to the His bundle or the early branches. What we don't know, and what we are speculating and going into the literature and going into our own experience, is about the arrhythmogenesis. For sure, mechanical trauma as one of the points that is discussed. Cardiopulmonary bypass, ischemia, reperfusion is one of the other points discussed, then electrolyte shifts, catecholamines, and so on. And looking at the literature, always young age, cardiopulmonary bypass duration, clamp time, inotropics, the use of inotropics, or the type of surgery are discussed. But there's a big mixture if you go to the few literature we can find about that. And concentrating on the both biggest studies that are available so far about this issue, one with 1,000 patients, one with 750 patients, more recent data. I think interesting, 5% or 15% postoperative rate of CHET. So this is a relatively high problem, a high load problem. But if you look for the markers that are maybe relevant for the incidence of this CHET, they are very divergent. So only in one of the groups, surgery was the issue, not in the other group. The only common link was the longer procedure duration or the longer clamp time. One prospective analysis, 1 year prospective analysis in one single center, 336 patients, or mixed patient cohort, all with congenital heart disease, 8% rate of CHET, postoperative CHET. And if you look for the congenital heart disease, there were the major ones underlying here. AV canal repair was in 21% of the patient was the underlying congenital heart disease. But I think of interest is that arterial switch and normal repair were another 2 big groups, and they have nothing to do with septal defect repair, at least at this stage. So surgery alone cannot be the issue. Risk factors here in this patient, in this cohort, younger age, longer cardiopulmonary bypass time, and higher inotrop score, which can be unmasking the patient with a worse clinical course. So again, surgery alone is maybe not the issue, but looking at pictures like this, I have always a little bit shaking, because this is a very, very close procedure to the specific conduction system. Just stitching or stretching or edema at this area must, to my understanding, harm in any way the survival of the the specific conduction system. So it's multifactorial and not defined yet. It's still an issue where we have to look at. Just coming to the very fast part, to the very last part, some anecdotal cases from the fast tachycardias of fast substrates. One thing which is very rare, to be honest, it's very rare, and we know we see this very rarely, but it's very interesting. In those with a left heterotaxy syndrome and AV canal, we know that they typically have the Mönckeberg sling. They have, let's say, a doubled specific conduction system, one at the roof of the AV canal defect and one at the bottom of the AV canal defect. And the interesting thing is that they have connecting fibers, the Mönckeberg sling, and some of them might have tachycardias using both of these systems. And this is one of my few cases I had in my hands. It was a very young patient with a heterotaxy syndrome. And you see here on the left panel, the EKG at a certain stage of basic rhythm. And this is another rhythm, so it had a wandering pacemaker, not very unusual in these young patients. But it showed us with just changing the input from maybe superior atrium towards a little bit more inferior atrium, you can see that you have a shift in the Qrs axis if you compare left and right, especially the inferior Qrs leads. So we have a shift because it's for sure always a fused activation toward the ventricle, but you have a preferred activation on the roof system when you're a little bit more up in the right atrium, or vice versa if you go to the inferior. So this can be, if you make serial EKGs, this can tell you maybe that the patient is having two different AV nodal systems already. And it's not only interesting, it is sometimes even important for the patient to know that, because if they have, on the other hand, this type of tachycardia, wide Qrs complex tachycardia in this case, you can understand a little bit better how the cause is, because the cause now is antegrade, so the atrioventricular conduction over the inferior system, because we have a superior axis in the inferior leads. And the backward activation is on the superior system. That's interesting because it helps you to understand how to make therapy in this case. And I just show you here the local electrograms obtained from the mapping catheter placed at the superior system. And this is a multipolar catheter, very small one, 2.5 French system, and placed down here at the inferior rim of the AV canal defect. These are the EKGs obtained, again with the with the catheter position. Here, the superior system, you see atrium, ventricle, and you see here marked His signal, which is normal in a normal heart. But at another place, you have another His signal from the second system. And this is something very, very interesting to see. And this is obtained from this electrode pair. And for sure, we were then deciding to block the superior system because the tachycardia was taking the inferior route on the antegrade manner. So this must be the more strong system. And I'll show you how this looks like. Giving current to the superior system, you have a change of the axis towards the axis we have seen during the tachycardia, taking exclusively the inferior system. And the patient was, from this on, free of recurrent tachycardias. Just a short word about atrial flutter. Atrial flutter is always an issue in these patients when we are talking about postoperative course. Here, a pacemaker leading a patient with a 2-to-1 relationship of atrium and ventricle, so easy diagnosis. 7.5 years old child with 17 kilogram. Here are the pacemaker leads. You can see here an RAO projection. And by chance, there was a leak in the intracardial tunnel. It was not following Murphy's law, where typically those patients have no leak, which needed, or who needed. In this case, both were present. And the tachycardia, for sure, always takes place in the area which is around the tricuspid valve annulus and the insertion of the inferior caval vein. And I just guide you through these pictures. As we have seen, and this is the tunnel, this is the tricuspid valve annulus, and this area is the cavo tricuspid isthmus where typically the tachycardia takes its way through. This is on the LAO plane. This is nothing very special. The only special thing is to come there and to make, let's say, the diagnosis, giving current, and for sure we blocked the tachycardia just by producing a linear lesion along this distinct area. And for us, always, it's not only important to block the tachycardia, it's always important to validate this, the creation of a linear lesion. And I just show you this using the implanted pacemaker system, so pacing from the lateral atrium. We wanted to see whether this conduction here is blocked. And if you just obtain the local signal, the local atrial signal here, when we have been with the catheter to the pacing site, expected to be early. Being on the line, you see a double signal, so this is really a pretty nice sign for an electrical dissection. And being on the other side of the block, now very late local atrial activation, so we were sure that the patient has a low rate of recurrence of the tachycardia. One word about atrial fibrillation. We see atrial fibrillation more and more in these patients, and there's nothing special to say because the techniques we have introduced in adult patients, so linear lesion concept around the pulmonary veins, is transported to these patients with the repair of congenital heart defects, as like those patients with AV canal repair. The only thing what I wanted to say is that we can do it and that we will see in future. I expect more to see more patients with atrial fibrillation, as these patients have a tendency for sure to grow older. Last but not least, looking at our own experience in Bremen, 15 years now I'm in Bremen, 27 patients with AV canal, when then 19 of them had EP intervention. So it's not a very high number. And you can see here the associated lesions they had, so a mixed population, I would say. And these were the substrates. So accessory pathways, AVNRT, so the accidental substrates, focal atrial tachycardia. Then for sure, high number of incisional atrial tachycardia. So this is an issue, as in all postoperative congenital heart disease on atrial flutter, the growing number of atrial fibrillation. And I just wanted to stress the point, we had no patients so far with ventricular reentient tachycardia. And we are getting referrals from all over the country. So we don't see them. Maybe we see them more in the operative centers. We are no operative center for congenital heart defects, so we have no own patient population. But we, as a referral center for electrophysiologic problems, haven't seen them. And interestingly, we had no ICD and CRT in these patients so far. I have to say, so far. Maybe it's a question of detection of the problem, or it's a question of that we have to wait a little bit longer to have the patients in a longer follow-up that we might see them. So in summary, the fast and the slow in 2016, we know we have a high variety of arrhythmia substrates in these patients, inherited, native cause, or postoperative. Still, it is challenging electroanatomy for surgeons as well as for interventionists like us. We have very often a complex intracardiac electroanatomic situation. We have quite often, I had not the time to go into details with these associated venous anomalies, which make the life very hard for us to come into the heart, or surgically restrained access, thinking of extra or intracardiac tunnels. And we have an unknown rate for ventricular arrhythmias and sudden cardiac death. And if we think in future, I would expect to have these postoperative problems a little bit lower, and a symposium like this is working in this direction because we gain our knowledge, we exchange our ideas, and this is to have less problems like this. Whether this rate is going down or up, I would expect, because of the longevity of the patients, it might rise. Role of atrial fibrillation, I promise, will be a bigger issue. And surgically restrained access, hopefully, is something of the past. And I would like to end with a short case, because this is the worst case situation we can have, an extracardiac tunnel without a leak. This says, okay, you interventionists, you have to stay out of the heart. There's no way to go in. If you don't have a cooperating surgeon like him in Kiel, it's an old friend of mine, or of us, Jens Hebe, making a leak and marking this. And I brought this case, this is warm, this is from last week, and it is only one last minute. And I say this to Joachim, who did this surgery years ago in St. Augustine at the very unknown former place. Now he is in Berlin, in the family. And he did this case, and if you look to the EKG, sorry for that, if you look to the EKG, you see pre-excitation. And this patient had no events for sure when he came to surgery, but now he came years after with recurrent tachycardias. He had a poor situation. Hemodynamic tolerance was very poor. Extracardiac tunnel. We made for sure, for the beginning an injection, you don't see any leak, anything else. But we knew from the report, Joachim has done a leak, and he has done more than putting a leak. He has followed always our discussion, marking this leak. And you see these two clamps, these marking leaks, so he adapted the lateral tunnel towards the free wall and marked this area. It was spontaneously, as I think, closed. There would have been no way for us to find this without these marks. With the marks, it was pretty easy, even for me, to go through there, bringing the catheter towards the accessory pathway. One catheter in the left pulmonary artery, because we have restrained access, still left pulmonary arteries just behind the left atrium to be able to pace the atrium. One catheter via the aorta into the right ventricle, so we have a CCTGA situation. And the most important catheter across the fortiodis leak towards the tricuspid valve. This is just to show we have funny pictures too. So this is, we try to reduce a little bit the amount of fluoroscopy for the orientation. And what I want to show you is that for sure we have the situation during sinus rhythm here. This is a local signal. Just believe me, this is wonderful. And this is very early. This is a situation where we should give current to block the accessory pathway, but not before showing that by blocking this accessory pathway, by pacing, that we don't see a His signal, because we don't know that the His or the specific conduction system is maybe parallel to this accessory pathway. If we burn, then the patient for sure will need a pacemaker, and we try to avoid this for sure. And then we have given current, and you can see now we have a normal EKG. And we started, if you have followed these times, we have started 50 minutes before. So that was done in less than 1 hour, just because this man has made the leak. Otherwise, this would have been a big, big procedure. That was my message for this, and thank you very much for your attention.